Hi, this is Elliot Fishman, and I'm live on YouTube, and it's great to be here. Today is Wednesday, it's 3 o'clock, and the new academic year has started, and we are, as we mentioned, pushing, trying to figure out what people would like to see on YouTube. So we're doing our 5-minute talks, 5 minutes live in person, and I have been addressing misdiagnosis, and I'm going to continue to do that. So let's look at misdiagnosis. So we've spoken about a few things. I gave a talk at the University of Penn meeting last week about misdiagnosis. You can give a 4-day talk about how many things we can miss, but let me just mention 2 things that you should be doing. If I ask the question, how many of you look at the scout view or topogram or whatever you call it on every case? Some people will say they do, but a lot of people don't. Now, it is true, in the old days when we had film, we always looked at the topogram because the technologists, when they shot the images, the first image they shot was the topogram, the scout view, and the last image was the scout view with the lines. But now it sits separate, and you have to open it on the PACS. And what people have shown, and we wrote an article, this was an article Pam Johnson wrote, that in about 2% of people, there's important information on the topogram that you really don't appreciate looking at the scan. Now, sometimes it's been things like you read the scan and you say, oh, there's residual contrast in the patient's bowel. And then you find out you were looking at artifact from a sponge. The patient never had positive contrast. Or remember, a text, the topogram is typically longer than what you're going to scan. And so on the topogram, you see a lung mass, or you see something in the patient's arm or higher up, and you don't scan that area. So if you only looked at the CT, you wouldn't have missed it per se, but it would have been on the topogram. So it's very important to look at it. Leonard Berlin wrote an article a number of years back in AJR making the point that there was a lawsuit in Chicago where there was a fracture that was missed on a pediatric skull that was really hard, almost impossible to see unless you looked at the topogram. And the topogram wasn't looked at, and that child died, so it was a tragedy. And it was a legal case, and the radiologist lost because the jury can see it, and they wanted to know why you didn't look at the topogram. And the radiologist said, we don't look at topograms. Well, the answer is I think he probably looks at topograms today. So that becomes very, very important. You got to look at the topogram, okay? Even if it's for a split second. People have written articles and said perhaps what you should do is when you have structured reporting, the first line should be topogram and say, I don't see anything, or I see something, or nothing additional, just to make you have to say something. Some people have often said that on the PACS system, it should open automatically to the topogram. So you have no choice but to look at it. Maybe that's the best way. People will then look at it. Okay, if it's there, you're going to look at it. So that's one thing. A second thing I'm going to mention is field of view. Now, we always tell a text to cone down because, if you have the whole area, the whole abdomen, and area around the patient, the images are really small. So target down. Target down decreases radiation dose. Target down also increases spatial resolution. Several areas we target down routinely. So the cardiac CT we target for the heart, the spatial resolution of the coronary arteries, and we also target down on the spine. But one of the things we always emphasize is, although you target down for optimal visualization, the patient has been scanned, the whole volume is there, you need to look at it. And all of us in cardiac CT will dictate the cardiac, but we'll also say the extracardiac portion of the exam, and we'll look at the entire lung and parenchyma and mediastinum, because on a typical, even a calcium score, you have about 60 to 70% of the volume of the lung, okay? So you got to look at it. You got to reconstruct it and look at it. The same thing's true in the spine. People target the spine, but you have back pain. There's been an article that made the point that 75% of things are missed in the abdomen if you only target the spine, and in about 3 to 5% of patients, there's important findings, because if you target the spine, you'll miss a renal mass. You may miss adenopathy. You may miss an aortic aneurysm. You need to reconstruct. I'm not saying reconstruct every 0.1 millimeter. Even every 5 millimeters would be fine. But you want to make sure you've looked at that area. You want to make certain that you've looked at everything that you've scanned. If you've used a radiation dose already, look at that region. And so one common error is not to reconstruct the full field of view. So here's my recommendation. You need to do it in the chest and you need to do it in the spine. You need to do it all of the time. Okay? Take a look at it. It takes a few seconds more, but it can make a very important diagnosis for that patient. And with that, I'll thank you for your 5 minutes, and we'll be back again with some more pearls and pitfalls and misdiagnosis in radiology. Have a great day, everybody.